In this lecture, we will discuss right atrial enlargement, including its EKG features and potential causes. The P wave of the cardiac cycle represents atrial depolarization. So if we draw out our complex here, let's draw here. We have our normal cycle with our P wave, our QRS complex, and our T wave. This portion here, our P wave, represents atrial depolarization. In sinus rhythm, the P wave is generally upright in the inferior leads, especially in lead 2, and left lateral leads 1, V4, V5, and V6. It is also inverted in lead AVR. As we will see, the criteria for right atrial enlargement generally assumes that sinus rhythm is present. Now, if you recall, because the sinus node is the normal pacemaker of the heart and it's located in the right atrium, the right atrium depolarizes before the left atrium due to its proximity to the sinus node. Therefore, because the P wave represents atrial depolarization and the right atrium depolarizes first, that means that the beginning of the P wave represents right atrial depolarization and the end or terminal portion of the P wave represents left atrial depolarization. Okay, so this is important to understand because it'll help us as we look at these atrial abnormalities. So again, our sinus node is this portion here. Notice it's in our right atrium. Because that's where it is, the right atrium will depolarize before our left atrium. And if we look at our leads, here's lead 2 and lead V1, the main leads that we'll look at. Notice that the initial portion of our P wave, so this whole thing here, is our P wave, and the same thing here. In V1 we have a biphasic P wave, but look here in lead 2, the initial portion represents right atrial depolarization, the terminal part represents left atrial depolarization. Okay, so you can think of the first third representing only right atrial depolarization, the middle third right atrial plus left atrial depolarization, and that terminal portion only left atrial depolarization. When we look at V1, which is a short axis view of the heart, we can really see what's going on in the atrium. The initial portion again representing right atrial depolarization. Notice that it's a biphasic P wave, but it's positive, this up, and then negative. Okay, so this is a normal P wave in lead V1. And then that terminal portion again represents left atrial depolarization. Okay, so this means that if we have right atrial enlargement, we're going to notice abnormalities at the beginning of the P wave, and then if we had left atrial enlargement, we're going to notice abnormalities at the end of the P wave. Now with right atrial enlargement, we will be looking for an increase in P wave amplitude, and when we look at left atrial enlargement, we're going to look for an increase in P wave duration. Okay, so that should make sense. Notice we said the beginning represents our right atrial depolarization, so things will move up in amplitude, and the terminal portion represents left atrial depolarization, so things will get wider or increase in duration. Okay, and in V1 we'll see them get increase in depth as well as duration. Okay, now if you recall, the initial P wave vector is directed anteriorly as it depolarizes the right atrium, while the terminal P wave vector is directed posteriorly as it depolarizes the left atrium. And because the right atrium is enlarged here, it will produce greater anterior forces. And this is why we'll see that the P waves will increase in height in leads V1 and V2 as they sit over the anterior portion of the heart. Okay, so look at our vectors here. You can see them in yellow. Okay, we have this first vector from the right atrial depolarization. So imagine our right atrium is enlarged here. And then this one that's heading towards the left, towards our left atrium, that's representing its vector. Notice that it's much smaller. Okay, so we have an enlarged right atrium. We're going to have a greater forces coming from the right atrium, a rightward shift in our axis, okay, and that's why you see this greater vector in that case. Okay, so the initial P wave is directed anteriorly. Remember, the right ventricle is the most anterior portion of the heart, and if we're heading towards that, that's where V1 and V2 sit. We'll see greater increase in amplitude in those leads. Okay, and then the terminal P wave is directed posteriorly. Remember, the left atrium actually sits posteriorly, so it will be heading away from leads V1 and V2. Okay, so our focus here is right atrial enlargement, so let's see what we should look for. Now we said that we're going to look for a P wave amplitude, an increase in it for right atrial enlargement. And there tends to be a lack of significant age-related variation in the P wave amplitude, and therefore we can apply these same criteria for both pediatric and adult patients. So let's go over that criteria. Okay, the main criteria relates to P wave amplitude, and we only need to have one of these to be present. Okay, in general, if the P wave equals or exceeds 2.5 millimeters in the inferior leads, so that's 2, 3, or AVF, or if the initial positive deflection of the P wave is greater than or equal to 1.5 millimeter in the right precordial leads, V1 or V2, then that suggests right atrial enlargement. Oftentimes, the best leads to look at are leads 2 and V1. So let's look at these criteria right now. So here's lead 2, here's lead V1, and what we're saying here, in those inferior leads, it has to be greater than or equal to 2.5 millimeters, okay? And if you look here, here's our amplitude of our P wave. This is our P wave. Notice that it's more than 2.5 small boxes, okay? So there's 1, 2, 3, almost 4, okay? So we meet the criteria in that lead, okay? And you can also check the other inferior leads, 3 and AVF. And then in lead V1 over here, where we have our biphasic P wave present. In this case, we're looking at the initial portion, okay? So not that end. We're looking at the initial and we're looking at the amplitude. And notice here it has to be greater than 1.5 millimeters. So here's 1, 2, and it's over almost 3 small boxes, okay? So almost 3 millimeters. So we meet the criteria in the lead V1 as well. So as you can see, it's not that bad. Just remember 1.5 millimeters in lead V1 or 2.5 millimeters in lead 2, okay, with sinus rhythm present, and you have the criteria met, all right? Now just let's go over a few causes of right atrial enlargement. The main one that you should be aware of is pulmonary hypertension, and this can be secondary to many conditions such as chronic lung disease like COPD, tricuspid stenosis, primary pulmonary hypertension, and congenital heart disease such as pulmonary stenosis or tetralogy of Fallot. If you think about these causes, right atrial enlargement essentially results from pressure or volume overload in the right atrium. Okay, so if we look at some of these, let's just erase some of this here. Okay, so notice from our right ventricle, we go out to our lungs, to our pulmonary artery. Okay, and that's the same thing here. Here's our right atrium, we go into our right ventricle and out to our lungs, okay? And if we have a backup of pressure from any pulmonary hypertension, whether it's stenosis of the pulmonic valve or COPD, a problem with the lungs, or an embolus or something going on, or even tricuspid stenosis, everything will back up and end up back into our right atrium. And because of that backup of pressure or volume, our right atrium will expand, and that's why we see these things on the EKG. All right, let's briefly review what we discussed before we end here. So again, the P wave represents atrial depolarization, and remember the initial portion is right atrial depolarization, the terminal portion representing left atrial depolarization. So what we see here is that the initial P wave is directed anteriorly, okay, and that's why we saw the vector going much more so in, remember the right atrium is heading towards the anterior portion, whereas the left atrium is heading more posteriorly, okay, their terminal P wave. And with right atrial enlargement, the main thing we're looking for is an increase in P wave amplitude. We mentioned 2 criteria, we only need one of them. In the inferior leads, if we have a P wave amplitude that's greater than or equal to 2.5 millimeter, that will meet the criteria. And usually we think of this and call this P pulmonale. Okay, and you can think of that pulmonale. Remember, we said most of the causes have to do with the lungs, right? Pulmonary hypertension. So that can be a way to help you remember that. Okay, that P pulmonale, or you can think of it peaked as like a TP. Some people use that as a memory aid. Okay, so again, inferior leads 2.5 millimeters or greater, and then in the right precordial leads, that initial P wave, right? We're only looking at that initial P wave that represents right atrial depolarization. That positive deflection should be 1.5 millimeters or greater, okay? And then we mentioned a number of causes, okay, and most of them have to do with the lungs, okay? We mentioned chronic lung disease, tricuspid stenosis, congenital heart disease from pulmonary stenosis, or even tetralogy of Fallot. Well, that's the end of this lecture. We discussed right atrial enlargement, including its EKG features and potential causes. I hope you learned something.